Good evening, everybody. Welcome to another installment of Taylor Tuesday. I feel a little lonely. My compadre, Mike King, who has moderated with me for weeks and weeks and weeks, was unavailable to be here tonight, so it's just little old me. I'm really excited about today's presentation. We have with us Dr. Donald Mrdjenovich, who's a practicing podiatrist in Altoona, Pennsylvania, and Ryan.sheffer, who's the Senior Director of Health Policy with SANUWAVE. For those of you who are not familiar, you'll learn a little bit more about it, but they're going to here to talk to you about UltraMIST, which is a device used for wound healing. I have to tell you that I had the opportunity at the tail end of my clinical practice career to have the opportunity to use this machine, and I was amazed at the results and outcomes that I got and the benefits that it was for my patients. But you'll hear more about that from our speakers. I'm not the expert on that, so I'm not gonna steal anybody's thunder. But I do want to welcome you to Taylor Medical, and I think you know that we've been doing this now since COVID started, and we've been trying to help everybody survive through the pandemic crisis and make your practice a better place. At the beginning, it was all about taking the time to see what we needed to do to come out of it. Well, now I think for the most part, I'm hearing really, really good things from around the country with people that are starting to come out of things, and patients are coming back. And hopefully, you utilize this time, and hopefully some of the Taylor webinars were helpful in getting you to restructure, reorganize, make things more efficient in your practice. And we'll tell you that we've archived all of the webinars. They're all on our website. So if you go to www.taylormedical.com and look for the icon that says webinars in the upper right-hand corner, all of the webinars are archived. And I also believe you have the ability to print them out as a PDF if you want to have your review things with your staff. But these webinars are made to help educate people and to help provide knowledge for you in your practice. For those of you who are new and are just signing up for the first time to a webinar and don't really know about Taylor Medical, I just want to share with you that this was a vision of podiatric physicians and leaders around the country to put something together, an organization together that would be able to provide good economic business advice, but also we want to educate. We're not here just to sell you a product. Even tonight's presentation, I think the UltraMIST is a great machine. We're here to teach you and educate you on how you can get better outcomes for your patients. Should you choose to use this technology, that's great. What we do in our practice, though, is we do free cost analysis. Anything that you buy or purchase or use in your practice, Taylor Medical has the opportunity to get a hold of. So, for example, tonight, this MIST machine is being sponsored by SANUWAVE. We have an agreement with SANUWAVE through Taylor Medical. Taylor Medical will do anything that you have in your practice. So if you haven't had a free cost analysis done by our team, then it's really simple. Send us an Excel spreadsheet that you have. If you're using certain vendors, you can actually download an Excel spreadsheet online. And then what you can do is you can send it to Taylor Medical at admin@taylormedical.com, and we'll do a cost analysis. And what we do is we try and do apples to apples, and I call it apples to apples and apples to oranges. Apples to apples is we're going to give you a cost analysis on everything that you currently use in your practice today without changing anything, other than, for example, if you're using a generic or a non-branded product from a vendor that is not our vendor that we have partnered with, we'll make that change. If you're getting McKesson Band-Aids and I don't work with McKesson, then we'll have a different substitute. We use Medline, it would be Medline Band-Aids or Curate Band-Aids, but that's just an example. And then we do what's called apples to oranges. We look at your products and we say, okay, we have very similar high-quality products that could actually save you additional money if you wanted to substitute those products. So basically, we're averaging anywhere in the, I want to say 12 to 20% on apples to apples, and probably 18 to 30% on apples to oranges on cost savings for your practice. So if you haven't done anything, please give us a chance, and we'd love to show you what Taylor's capable of doing. And I am going to get started with the presentation from Dr. Mrdjenovich. So hold on one second.
UltraMIST Therapy is non-contact low-frequency ultrasound technology to promote wound healing, including when standard of care has failed. Pain-free ultrasound is transmitted from the device head to the wound. This leads to the stimulation of cells within and below the wound bed, compressing and stretching cell membranes. Another effect of UltraMIST therapy is vasodilation, which increases oxygen, nutrients, and perfusion to the tissue. This cascading effect stimulates the wound, accelerating the healing process. Increased blood flow to the wound bed increases angiogenesis. Macrophages release growth factors including vascular endothelial growth factor, VEGF, and platelet-derived growth factor, PDGF, that enhances the removal of damaged tissue by neutrophils. Additionally, UltraMIST therapy removes common barriers to healing by reducing pro-inflammatory cytokines released by inflammatory cells. It also lyses the bacterial cell wall, resulting in a reduction of bacteria on the wound surface. UltraMIST therapy has been clinically demonstrated to promote wound healing. In a chronic wound study, there was an 85% area reduction in 7 weeks. 42% of patients healed at 12 weeks, compared to 24% with standard of care. Take back control of the wound with UltraMIST, the only low-frequency non-contact ultrasound device designed for promoting wound healing.
Hello and welcome. My name is Jack Schlotwig. I am the Chief Revenue Officer at SANUWAVE, where energy is first. It is my pleasure to introduce to you our speaker, Dr. Don Mrdjenovich. Dr. Mrdjenovich has served as Assistant Chief Editor for the Journal of American College of Clinical Wound Specialists, a founding fellow and founding director of the Board of the American College of Wound Specialists. He was a past president of the American Board of Wound Management. Ladies and gentlemen, it is my pleasure to introduce to you Dr. Don Mrdjenovich.
Hello, thank you, Jack, for the kind introduction. And today, I'd also like to thank SANUWAVE for inviting me to speak about UltraMIST today. So today we're going to discuss in further depth what you just saw in the video, how the UltraMIST actually removes barriers and promotes healing. So today we're going to talk about pathways to improved wound healing outcomes. So as you can see in the video, as this goes, I'd just like to remind you, what is UltraMIST therapy? It's a low-frequency, non-contact, non-thermal ultrasound. This technology in wound care removes barriers and promotes wound healing. This advanced wound healing therapy has the advantage of having a pain-free delivery through a fluid, which is usually a saline mist, as the medium through which the energy travels. I would like to just highlight the video. You did see that the ultrasound applicator was a little distance away from the foot ulcer. We do want to make sure that that applicator is close to the tissue of the wound as possible without making contact, which we'll discuss that a little further. But I'd also like to highlight at this time what UltraMIST therapy is not. It is not a debriding device. There is no PSI involved with this device. It is not a high-frequency, high-intensity thermo or diagnostic ultrasound, and it is not pulsatile lavage. So UltraMIST therapy, as we think about how do we treat the chronic wounds and what is our goal? Our goal is always to move that wound that's in a chronic state out of that chronic state and into the healing phases of for our wound to heal. So when you think of UltraMIST, you can't just think of the hole or the ulcer. You need to also consider the surrounding tissue. So in summary, And the UltraMIST basically decreases that surface bacteria, and it also decreases the bacteria beneath the surface. You want to think of the angry peri wound as well, where those inflammatory cells hang out. So these ultrasonic waves can also reduce those, and also penetrates to the depths where it can also increase perfusion. And we're going to discuss all these three topics in a little further detail. But once again, I want to just remind you that when you do UltraMIST, you want to make sure that you hear that gurgling sound, which we heard in the prior video of on that slide. That is considered the optimal operating distance. You want to also think that when you have a larger wound, you want to go in a slow, methodical method. You want to perhaps create a grid. You want to create a pattern that you know that you're going to continue to cover all that area in a methodically slow area, with the applicator being as close to the wound and tissue without contacting it. So what is the physiological impact that this low frequency ultrasound has on our tissue and our wound? The UltraMIST delivers a low frequency 40 kilohertz non-thermal ultrasonic energy without any surface contact, as we've mentioned before. And this is done through a fluid medium, usually saline. So this creates an ultrasonic mist that's delivered to the wound bed, and then the energy continues to travel below the wound surface. So what does it actually do once it gets below the wound surface? These ultrasonic waves actually create an energy that creates a pressure wave, pushing these cells and then affecting the adjacent cells, and this at the surface as well as below the wound surface. These sound waves can penetrate into and below the wound bed to mechanically stimulate these cells. And these mechanical forces actually cause microstrains that can deform these flexible cell membranes, causing a physiological response to this membrane deformation, which then is an end result in promotion of healing. And again, I want to just emphasize the fluid that is usually used in this ultrasound is saline. So how does UltraMIST work? What's its mechanism of action? So as we said earlier, UltraMIST is an excellent modality to remove barriers to healing and also to promote healing. We know that some of the barriers that we face in a chronic wound, a wide range of bacteria. We know that there's biofilm, there's sustained inflammation, and there's MMP9s that cause this chronic inflammatory state, or this cytokine storm that keeps the wound stuck in the chronic phase. So the mechanism of action of UltraMIST actually reduces these bacteria, disrupts this biofilm. It will reduce the sustained inflammation and reduce the MMP9s. And it promotes healing by increasing perfusion through vasodilation, which we will speak to all these topics further in the next few slides. And by increasing this perfusion through vasodilation, this will translate into increasing oxygen and nutrients to the tissue, and thus promoting healing. So before we discuss the mechanisms of action a little further, how it removes barriers and how it promotes healing, I just want to mention that the UltraMIST has over 16 years of research compiled. There are mounds of evidence. If you have an evidence-based clinic, or if you're an evidence-based practitioner, which now these days we have to be with different insurance companies and Medicare putting us on the hook, we can't just rely on tuition. The evidence is over 55,000 patients were studied in meta-analysis. There's also randomized controlled trials, prospective studies, retrospective studies, and even observational studies. As you can see in this upper slide in the little takeout, this is the driver study, which actually studied 444 patients. And we see in this study that almost 86% of the area was reduced in the mean of 7 weeks, with a volume reduction as well as healing time being 6 weeks in approximately 33%, and 42% were almost healed within 12 weeks. And finally, this study also showed that in 80% reported a reduction of pain from baseline. So there's a large amount of evidence showing reduction of area, reduction of volume, and actual healing time of wounds, as well as pain reduction. So I think with all this evidence in your back pocket, you will be able to use this modality, knowing that you're doing something, a service for your patients that has a lot of research backing it up. So let's talk a little bit about the factors that impair wound healing. So we know that high levels of bacteria, presence of biofilm will all impair our wound healing progress. The presence of biofilm, there's that sustained inflammation, there's those high level of MPPs that just keep this wound in a chronic state. We also know that if there's decreased perfusion, which then can also impair angiogenesis, decreases the amount of growth factors that are formed, as well as insufficient collagen deposition, and all the good cells that we need for the wound to get out of that chronic state just aren't there. We also want to think about, we can add factors such as inadequate offloading, or if it's a VLU, or you're thinking about inadequate compression. Other factors in this list, I know that everyone can think of many factors, but you can also add poor nutrition, poor adherence to instructions, and perhaps they don't even understand instructions. And you can also think about poor blood sugar control, which all can impair your wound healing and get that wound stuck. So what I'd like to do right now is discuss bacteria. So we know that all wounds have some level of bacteria. There's the colonized bacteria, especially our patients with diabetes have a multiple amount of different types of bacteria. So we know that we want to keep that wound in state to the left. We don't want to have it being infected at the 10 to the 6th power of bacteria present. We don't want it to become critically colonized. So I'm going to show you some studies that show how the UltraMIST can actually keep us away from the critically colonized and infection in wounds. This study, which was done at the Mayo Clinic, actually demonstrates how the bacteria was actually, by the mechanical stresses caused by the low frequency ultrasound energy, can actually result in bacterial cell death and the reduction of bacterial count. Even our most difficult to treat, the VRE, the MRSA, the E. coli, the Acinetobacter. So what we show in this study is, this study, which is remarkable, these were only done after 2.5 minutes. The minimum treatment using UltraMIST is 3 minutes. But how this works, the bacteria have very rigid walls. If you think of an eggshell, so the ultrasonic mist just cracks those walls and just obliterates this bacteria. So it's very important to think about UltraMIST for those patients that if you want to reduce bioburden, this will possibly reduce the amount of oral antibiotics, even IV antibiotics, when you're using the UltraMIST. Another impairment is the presence of biofilm. We all have heard recently about biofilm. In fact, in about 60 to 80% of chronic wounds, we see that biofilm is present, and this is mainly located under the wound surface. And we know that we can debride a wound one day, and with the next time we see them, that biofilm is right back. In fact, biofilms have been shown to reestablish within 24 hours after debridement, and some studies suggest that immature biofilm starts within 4 hours. So how this biofilm protects itself, it creates this extrapolymeric substance, or EPS, is a survival mechanism. It's that slime that we see. So what this does is it creates a metabolically inactive bacteria. So we know our oral antibiotics are antimicrobials or antiseptics are basically ineffective because there's no metabolic activity. It's also suggested that in our postoperative incisions, that when we see incisional dehiscence, this may also be the result of biofilm that is under the surface and just waiting to break out, breaks down the incision, and you end up with a open wound once again. So, and we're going to demonstrate a case study at the end that shows this in further detail. So this study done at Northwestern University, this was showing on the left the control. This was an untreated rabbit ear. You can see a large amount of biofilm present. On the right is after MIST treatments. These were 3 treatments done every other day for a period of 6 days. So what this reveals is it shows how the MIST treated wound actually dramatically reduced the density of the biofilm in large amounts, and you actually have a visibly bare wound bed. So therefore, you have granulation tissue that is now more receptive to your treatments. And this is a pretty remarkable demonstration of the effects of the ultrasonic waves of UltraMIST on biofilm. So another way that the UltraMIST improves wound healing is by increasing perfusion. So the effect of MIST on perfusion over time is demonstrated in these slides. So the first slide is a wound. It could be a diabetic foot ulcer. It could be a VLU. It can be any kind of ulcer. These first 2 slides show 5 minutes pre-MIST. And through Doppler technology, it's showing the amount of vasodilation in red. But what's remarkable about this study is even at 5 minutes and 10 minutes after the treatment was completed, the vasodilation and perfusion has continued to improve. So, and if you compare the 5-minute slide, which is the 3rd picture compared to the 4th, it's even increased more. So when you think of this, you could be treating your patient, and by the time you have them dressed and put their bandage on and they're on their way to their car, the UltraMIST is still working for your patient, increasing that perfusion through vasodilation. And this translates into more blood flow to the wound, providing those good cells that we need to heal that wound. So UltraMIST therapy. So we talked a little bit about how it removes barriers and how it promotes healing. And so then we think, well, okay, we want to use it. So where do we want to use it? You can use this in any type of acute wound or chronic wound. You can use it in deep tissue injuries. You can use it in burns, any kind of chronic wounds, your diabetic foot ulcers, your venous leg ulcers. You also want to consider using it in your wounds that maybe they're too painful for debridement. Maybe your pyodermas, your vascular type wounds, or somewhere where maybe a wound's just contraindicated for debridement. This actually can promote healing, decreasing that bacterial load, increasing that vasodilation and perfusion. It's also safe to use over exposed tendon, bone, arteries, and veins. You don't have to worry about desiccating the tissue or dehydrating the tissue in any way. And it is also safe to use over metal hardware. It is non-thermal, so therefore it will not affect the metal either within the wound or surrounding the wound. Contraindications, any wounds that are over or near cancer cells, you do not want to use this. I recently had a patient presented to me with bilateral ankle and lower leg ulcers. Patient did happen to also have diabetes. However, she reported that she was recently being studied for any kind of cancer. She had several lesions that were recently biopsied by the dermatological oncologist. So, and they were looking for squamous cell, and she did have a history of squamous cell. I just decided that UltraMIST, even though on the surface was going to be an excellent treatment, I avoided this modality. You also don't want to use it over electrical implants such as pacemakers or over and around pregnant uterus. Now, I do want to say also, patients that have osteomyelitis, the diabetic foot ulcers with osteomyelitis, the UltraMIST is not contraindicated. In fact, there are some studies that show that these ultrasonic waves not only penetrate the surface and beyond, but it can also penetrate to the bone and to the opposite side of the limb. So if you have a patient that is in that initial phase of osteomyelitis, this may actually help reduce the potential for IV antibiotics or even amputation. So when do we want to use UltraMIST? What's our goals of treatment? So anytime we want to do wound bed preparation, we want to initiate UltraMIST therapy as part of our wound plan. We want to apply those cellular tissue products. We want to do a split thickness skin graft, or even sometimes if we need to do some tendon repairs or other type of surgical intervention, some surgical offloading. The UltraMIST is a good way to prepare the wound bed. Also, if you want to promote and accelerate wound healing, of course, as we discussed, anytime we need to control biofilm and bioburden, which is in almost every 60 to 80% of our chronic wounds have biofilm. Anytime our goal is to increase granulation tissue, we want to improve that wound to the point where that granulation tissue is nice and beefy, it's up to the surface. We've now prepared that wound bed for a graft. Perhaps we want to get that wound to be smaller because it's just not feasible for us to put the cellular tissue products on a large wound, and we want to decrease the size using the UltraMIST to do this. And also for wound closure, our Dehiscence surgical incisions. This is an excellent modality to promote wound closure in those Dehiscence incisions. So treating with UltraMIST, our plan of care, first, the CPT code is 97610. It's a Category 1 CPT code for UltraMIST Non-contact Low Frequency Ultrasound. This treatment is to be used 2 to 3 times per week and is to be used when it's considered reasonable and necessary per Medicare guidelines. Our plan would be over a 2 to 6 week treatment plan, ideally, with weekly wound assessments and measurements. And we want to be able to document observable, documented improvements in the wounds. And these should actually be evident after 6 treatments. So after your 6 treatments, you want to measure your wound. You want to say that see if it has improved granulation tissue. Has the pain been reduced? Has the necrotic tissue or wound size been reduced? You can also add in there decreased drainage. But you want to make sure that these are documented, that you can actually prove that there's improvement. You can then continue until you're ready for your skin graft or your CTP, or if you want to continue because it's reducing the pain, etc. So when do we want to discontinue MIST? You want to discontinue MIST when your wound has progressed to the point where, okay, I believe this will continue to heal using standard good wound care alone. Perhaps it's now prepared for a graft or other measure. Also, you want to discontinue this when it's no longer demonstrating progress. So the utilization guidelines state that continuing without improvement after 6 treatments, as we mentioned above, is not considered reasonable and necessary. So this is the time you want to stop and reassess and determine the cause. Perhaps they're not adhering to their offloading instructions. Perhaps you need to reassess their lower extremity perfusion and vasculature. Maybe another PVR or an arterial ultrasound needs performed. You also may want to consider this wound just is not healing. It's not acting the way it should. maybe you need to biopsy it. We always need to have that in the back of our mind as well. So now that we've discussed all the principles of how UltraMIST removes barriers and promotes healing, I would just like to share with you one of my own case studies, which I found to be very interesting. This was actually a surgical dehiscence of a diabetic foot ulcer. This patient was a 73-year-old female. She had type 2 diabetes and multiple comorbidities, hypertension, heart disease, venous insufficiency. And she was a non-smoker. However, we did do non-invasive vascular studies, which actually showed mild PAD with no plaque formation of the lower extremity, which was shown with arterial ultrasound, which, as we said early in the talk, the arterial ultrasound is not the same kind of ultrasound as the UltraMIST. So this patient was done in an in-office setting. We have an in-office type wound clinic. This was a surgical incision that had dehisced after 3 weeks. We had planned a sesamoidectomy. She had had a chronic ulceration, which was not healing, and it was determined that the sesamoid should be removed. Of course, other studies were performed prior to this showing no osteomyelitis, no infection. So this was a pretty clean, straightforward wound that just needed a sesamoidectomy. However, after 3 weeks, the incision had dehisced. The sutures had totally popped out. We had done a total of 5 UltraMIST treatments twice a week. For this patient, that was convenient. This was in the middle of winter. This was at my office that was kind of out in the country. So transportation was an issue. However, twice a week was satisfactory. In between UltraMIST treatments, we did local care with a silver hydrogel and a foam dressing, and we offloaded her in a removable walking cast. She was not able to be non-weight bearing, but she was able to use the removable walking cast with a walker. And our goal was we wanted to prepare this wound for an application of an amniotic allograft. So this was demonstrates after only 4 treatments with UltraMIST. The first picture is what it presented after the dehiscence when we decided this needed to be treated. You can see the swelling and the inflammation around the wound, the devitalized epidermal tissue, the necrotic tissue and fat at the center of the ulcer, and it's just an angry looking ulcer. So you can see the slide on the right. After 4 treatments, we have increased the granulation tissue. We have decreased the peri-wound swelling. It just looks like a better foot. There is some fibrin still. The beauty of UltraMIST, it actually can soften up that fibrous tissue, so we were able to debride this. And of course, you want to debride and clean the wound like you normally would after each UltraMIST treatment as well. So this is after 5 UltraMIST treatments, approximately 17 days after we decided to start the UltraMIST. And nice granular tissue. We can see that there's good perfusion there with the bleeding. And we felt that at this time the wound bed was prepared and was ready for the application of dehydrated amniotic allograft at this time. So this is basically a timeline. The middle slide is showing you when we determined that it was closed in January. There was still maybe a little bit of weak tissue there. So we revisited it in another week or two, determining that this was, the area was preserved, there was minimal scarring noted, and we had a viable full closure. So this was over a course of 8 weeks, 3 months. This patient has a her foot back. This patient's biggest goal was just that she wanted to get back to the bowling alley. So she was able to do that. I do still currently see this patient. I see her about every 4 to 6 weeks just to keep an eye on her. She, of course, is in multi-density inserts and extra depth diabetic shoes to protect this stable foot. And I can say that she is remarkable. in the fact that she has was adherent to this and this treatment. The outcome for this patient using UltraMIST. So use of UltraMIST for this patient, we can see that it increased local perfusion and vasodilation. It decreased the biofilm and local wound inflammation. It also accelerated tissue granulation to the wound bed, and it accelerated the stability and wound edge migration, and prepared it for the application of a human dehydrated amniotic allograft, which then increased the prospect of closure. But I think the best outcome of this treatment is that her outlook improved. As the progress, she recognized the progress, seeing is believing. She realized it was non-painful. She was seeing progress. Of course, I had to show her this through a mirror, but she just was really happy over these 2-3 months. Because remember, prior to this, she had had a chronic ulceration that was not really being treated by anyone. And she went from a surgery with a sesamoidectomy that then the incision dehisced. 3 weeks later, her hopes were kind of, I'm never going to have my foot back. We introduced her to UltraMIST, and we put on a allograft, and she was happier than any patient that I've had. So I thank you very much for your attention and your time, and I would say at this time we are ready for any questions and answers from the audience. Thank you again.
Hello, can everybody hear me?
Thank you very much.
Yes.
Oh, I'm sorry. Can everybody hear me? Yep. So thank you, Dr. Mrdjenovich, for that great lecture. I'm going to turn it over to Ryan.sheffer, who's going to talk a little bit about MIST reimbursement.
Yeah,
Ryan?
Thank you, Dr. Kraus. You can hear me, correct? Okay, I just want to check. And thank you, Dr.
Yes, we can.
This is the first time using this particular presentation, so I just want to make sure I'm talking to everybody out there. So thank you so much for having us from SANUWAVE. I'm the Senior Director of Reimbursement here. Thank you, Dr. Mrdjenovich, for that great presentation, as always. And again, thank you, Dr. Kraus, for having us. So as always, when we do these presentations to physicians' office and health systems, we want to make sure that not only does the therapy work, but are you getting reimbursed, and can you, is it something that you can make, something that you can make and you put into your practice and make revenue off of it and treat plenty of patients with it. So I'm going to kind of go over some of the coverage, some of the payment, and then what is the ROI potential. And again, I always say that this is a demonstration. So depending on where you live and what health system you work with, somebody might want to go on mute. I keep tapping. So these, depending on health systems, your outcomes on your ROI might be different, but we have some exciting news to share around the reimbursement that just happened, effective this year. So I'll start with that. So, there we go. So. Really, right today, as we speak, we don't have much commercial coverage. The opportunity is all on the Medicare, Medicaid side of things. The good news is when we did this review of the data of the patients that would be using MIST based on the same criteria that Dr. Mrdjenovich reviewed, 76% of all VLUs and DFUs affect people, over 65. So these are 68% of the wounds that are covered through Medicare. So we kind of know that this is a great opportunity for offices today, even with just the Medicare opportunity. And that also includes Medicare Advantage for most national payers in your areas. So that's the good thing. We are working very diligently on gaining that commercial HMO, PPO customer out there for you. And we do have some new health economics studies coming out in Q4 and Q1, and some clinical studies coming out. So that will probably go a long way in 2021 in gaining that commercial coverage that people ask for. But the good thing is today, you're going to have a lot of patients in your practices that are covered currently with the Medicare coverage. So the in-office opportunity really went to a different level this year in 2021. So we worked very hard back many years ago, and we had a person that's part of our health economics study that she presented to Medicare. And finally, over the last couple of years, we've gone from a very low rate, about 145 back in 2018. It went up to $230.29 in 2019, and then last year we had a 43% increase for 2020. Amazing news. And so our national average now for per treatment is almost $330 per treatment, national average. That's a 43% increase. That's unheard of in this day and age when you're looking at CPT codes, especially a CPT code of this age that's been around for a while. So, and we anticipate, based on my discussions with CMS, that this rate will probably maintain for many years. So the opportunity is now. Unfortunately, this year being a pandemic year, we didn't really get to explore this growth. So we feel that, when things clear up, and to Dr. Krause's point, that when things get normalized more and you're seeing more patients and they feel free to come in, that this rate's going to be a very good opportunity for all offices that are using the MIST system. So the physician fee for facility, if you're using a facility, would just be $19. So it's a nice little RVU fee, but not as well as in just an office per application. So in the hospital outpatient setting, we see this best position for cost savings in the wound care clinics and the podiatry offices for the DTIs and the deep tissue injuries and pressure ulcers, like Dr. Mrdjenovich talked about. So the payers and a Medicare system really likes to see this used, because it's we're getting the healing rates that the wound vacs and the grafts get, and the HBO at a much lower cost to them. And that's what actually our health economic study shows. So when we publish that, that will confirm what everybody's seeing with the cost of this system compared to the other standard care. So it is covered under the DRG and bundle payments in the hospital outpatient. And so that's paid at about $175 for that APC 5051. So good payment. That's basically where we're at today. So you can see that we have 100% coverage in the max. That's 43 million covered lives for this procedure for the Medicare patients. Currently, there's active LCDs for 5 of these regions. The 3 that don't have an active LCD, Noridian, NGS, and CGS. Of those 3, Noridian is actually currently working on an LCD, so we anticipate an LCD for MIST in 2021 with them. So there'll just be a couple MACs that don't have an active LCD that you can reference, and that's really important for when you're working with commercial Medicare Advantage plans, to have a reference point for them to say that, yes, this should be covered for those patients. But currently we are paying Medicare MACs, all the MACs are paying claims. Some just don't have an LCD or article to reference, but that is not an issue. So what are the indications and patient selection criteria? Dr. Mrdjenovich did a great job of showing this. This is actually from the LCD. So this is what you would be looking for when you're working with a Medicare patient. Dr. Mrdjenovich already kind of went over most of this, but these are failed conventional debridements, too painful for sharp excisional debridements, contraindications for debridement. And just really the main one is no signs of really much improvement over the 30-day of standard foot care or wound care. So other than that, it's pretty much for any wound. and it can be used for wounds, burns, ulcers, any type. So it's really open on what they're looking for treatment on the Medicare side. This might change as the criteria might change when we look to go and we gain commercial coverage, but most of the time they do follow these Medicare guidelines themselves, and that's what I always push. So we don't foresee that commercial payers, when they do cover the 97610 in the future, that it would be much more difficult to gain these patients that you can see in Dr. Mrdjenovich review prior. So this, what is the ROI? This is what everybody kind of wants to know. If I purchase a system or rent the system, what am I going to be looking at? I want to recoup. I want to, I've heard too many horror stories with too many medical devices where, they promise you the sun and the moon, and then you get it in there and you can't get anybody covered. And when you do, it doesn't pay much. So we kind of look at this, the way this would be in a common practice when the MIST system would be implemented. And that's, when you get to the specialists and with the Talar medical groups, the podiatrist groups. So this is weeks 3 and 5 after a standard of care does not, after that 30 days is not working, where the debridement is, the patient has experienced too much pain. And, instead of going right into HBO or negative pressure or continue just to debride and cleanse, that's when you're going to implement UltraMIST right away from weeks 3 to 5 and all the way up to Medicare allows for 18 treatments. So, that you can extend out those patients. The most common practice we've seen is patients, especially in a time of COVID, is 2 times a week is what you want to do for MIST treatment. And so if you can get them in for 3 times a week, that's great. I'll talk about kind of how you bill. One thing, this is a sometimes therapy. So you cannot bill any other codes with the 97610 UltraMIST code. That's probably the most common question we get. So how we would do it during weeks 3 through 5 or 3 through 6 is you would debride, and then you would do the MIST treatment, and you would not bill any EM codes or any additional codes because they will pay. The UltraMIST code will probably get kicked back. So this is what kind of would look like. This is the next slide as we build it out. Come on. For some reason it's not. There we go. So this is your ROI for DFU example. So you would debride in week 1. The national average being 329. Again, it might be different in your area. In some areas, it's much, it's even better. In California, it's a national average of over $400 per treatment. So let's just use the national average minus the $55 on average for disposable the applicator. This is not taking an effect of any rental or purchase, but just your disposable portion. So on national average for debridement, depending where you are in the country, $100, $80 to $100. And then you're going to do UltraMIST for visit 2 and visit 3 during that first week. In weeks 2 through 8, you're going to debride maybe that first visit, and then the exceeding visits for that week, either 2 or 3 per week, if you can get the patient in. And then hopefully by that week 8 or 9, you're going to be seeing that wound close, much like as in the case study that Dr. Mrdjenovich just presented, where you can use your skin sub applications. And we're not going to do an ROI on that. Or you can continue all the way up to 18 treatments and continue just MIST if the wound is healing nicely. The 97610 can be built up to 6 times for the first 4 weeks without any prior authorization. The great thing about SANUWAVE is that we have a free reimbursement support team. All you would do for each patient would be putting send in a patient intake form. They would get everything approved. They would check benefits. They would get back with you on a benefit verification, and the patient would be off and running. There's no prior authorization required. The other thing you might need to do is document healing through that, that first 2 to 8 weeks. So if the patient isn't healing, then sometimes Medicare has said, we want some documentation that the wound is healing. And you would probably be at that point where if it was not healing and something was going wrong, that you would just stop on your own anyway. So and we can have questions, you can talk through this, but you're going to look at this, you're going to see that the reimbursement using the 329 national average for each week, being in that $5,000 to $6,000 range, you're going to very easily recoup your cost on the actual device over a course of, you're talking 10 patients. And if you have, 20, 30 patients that you're missing a month, you're going to pay this system off very quickly and then be in a profit situation. So, and that's where everybody wants to be, of course. So this is all because of this massive increase over the last 2 years, especially into 2020 and beyond, on this particular CPT code. And that's it for reimbursement. I wanted to give you guys just the basics. We do provide reimbursement guides. We provide anything you need as far as helping you with appeals and things like that. So if you ever got into a situation where one didn't get approved, in fact, we do that. We're working on one right now with a commercial payer, and so we help out with in any regards to if a claim were to get denied for a commercial payer as well. So. And that's pretty much it. I'm going to let Wes, are you going to talk about the year-end promotion?
Yeah, I certainly am. Thank you, Ryan. My name is Wes Snodgrass. I'm Senior Director of National Accounts and Business Development for SANUWAVE. I greatly appreciate everybody joining us tonight. As we all know, the UltraMIST platform is on our Talar medical agreement. And heading into year's end, to tie into this Talar Tuesday, we're offering a year-end promotion. We have a 30-day rapid evaluation on the UltraMIST system. The systems are provided at no charge. Our applicators must be purchased in order for you to bill Medicare. So those are provided at a Talar GPO contract price, which is very attractive. And in terms of our units, we have partnered with Talar's capital financing partner, Partners Capital. As a matter of fact, Mike Geske, who is their chief sales officer, is going to be in our chat room to answer any questions that may arrive about that. But what we're offering is a 24-month 0% financing for November and December purchases. The contracted price on the Talar agreement is $29,000. That comes out to 24 equal payments of $12,0833 plus tax. As I mentioned, here is Mike's information. He has experience in financing capital in plastics, in veterinary, and ortho, really all across the spectrum, and is very hands-on in articulating to you what the financial benefits are from an ROI perspective of capital purchase. We also, I will say, we offer a rental program under Talar as well, with monthly rental on the MIST system. And then all applicators during the months of November and December will provide a 10% rebate back directly to the practice on all applicators purchased during that time frame. So you can take advantage of a no-charge evaluation. You can look at no-charge financing. Then you can make the decision of what is better for you from a rental or a capital purchase. But again, for those last 2 months of the year, we'll rebate you 10% on all of your disposable cost. So with that said, that wraps up the presentation. We're going to move into a Q&A here for the next 10, 15 minutes, however long that goes. And I'll turn it back over to Dr. Kraus. Thanks, everybody.
Thanks, Wes. Thanks, Ryan. Thanks, Dr. Mrdjenovich. Just want to answer some questions. I've got a few questions right here. I'm going to get started. I've actually got quite a few, Dr. Mrdjenovich. So I'm going to fire them at you and let you answer them. How's that sound? The first question I have is, when treating difficult to heal wounds like pyoderma granulosum that can take months to heal, do you find insurance will cover beyond the typical 6 weeks?
Yeah, as long as you're documenting positive change, decreased size, decreased pain, decreased drainage, you can go. They initially say 18 visits or treatments, but that's not a lock stop. As long as you can provide medical necessity that this is actually helping the patient, They may ask you after 18 treatments or 20 treatments, okay, we need some notes to verify this. But yeah, so definitely when you have those hard to heal wounds, as long as you're being reasonable and your documentation backs you up, they'll let you continue several weeks past the 6 weeks for sure.
Dr. Mrdjenovich, I'm just going to ask you because I do a lot of health policy billing and coding, and I know Ryan's in the background. I know that they allow the 18 visits. So do you recommend after a clinic actually gets to that 18 visit that they prior authorize or get some additional visits? Because I guess you don't want to get into a situation where you're doing the right thing for the patient, but they're not going to cover it. Do you recommend doing an advanced prior authorization if you're going beyond 18 visits?
So I've been using the MIST in our office setting for 5 years, and we've never had to do a pre-auth after the fact. It's always been, our documentation, they've asked for it after the 18th or 20th visit. In my area, it's actually 20 is when they tend to ask us. But the documentation always backs it up. So, yeah, I don't really get pre-authed after 18. It's just and to be honest with you, I rarely go past 10 treatments. I mean, this machine is so amazing, increasing the granulation tissue and getting that wound. Of course, you have to use your judgment. When you first start using it, you're going to be thinking, oh, how long do I use it? But after a while, you just get a feel for it, and you know that, this is going to be 6 treatments or 10 treatments. And then you do your grafts or you do whatever. And, then you take a pause for 3-4 weeks, and then you can start it again because it's a new event. So it works out pretty well that way. But I rarely go up to the 18 mark.
Is this something that you as a physician have to provide, or can your staff do the treatment?
So the staff can do it. The physician has to be around, but all my MAs and my LPNs are trained to do it. So, and it's very convenient because I'm in one room and they're in the other room. In fact, today I had a patient and he was just in there for MIST. I just popped my head in. He just had a question to see am I going to still evaluate him on Thursday? Because we're kind of getting him ready for a graft on his wound. So, they're doing that. I'm doing another patient, reproducing myself, which is always a good thing for a clinic.
Great. So it can MIST be used after an allograft is placed? And if so, how much time do you need to wait before using MIST again?
There's no contraindication that it's not going to hurt it, because all it's going to do is increase the perfusion. So usually after I prepare the wound bed, do my 6 treatments or 8 treatments, I put on my allograft or my CTP, whatever it is. I usually have this 21-day rule where I won't put another graft on for 21 days because I want to just see what the body does to it. But usually at that 2-week mark, I'll say, okay, this patient's going to need a graft next week. I'll usually get in 2 to 3 more MIST treatments as a wound bed prep, get any biofilm that might be trying to develop any bacteria. So you can do it. I think scientifically you can do it the day after if you wanted to, but it really makes no sense to do that. So usually 2-3 weeks when that wound's stalling, you documenting the wound's stalled, you're ready for another allograft, whatever your choice is, then you're basically going to start to stimulate it again with the UltraMIST for, I usually do 2, 3, 4 sessions before I can get that extra allograft on them.
Okay, great. I noticed that you were I'm reading the questions and I'm kind of paraphrasing them a little bit. I know throughout your presentation, you talked about the utilization of saline. Is saline the only fluid that people use? I mean, do they use lactated ringers? Or is it just, straight saline?
So saline is the basic fluid because it's not about the MIST, the saline. It's not about the fluid. It's about the ultrasonic waves. That's what's doing all the work. That's what's breaking down those bacterial walls. That's what's making that cascade of tissue move and increasing angiogenesis, etc. So some people do use Vosh, the hypochlorite solution, if they're having an odor problem. And that's really the only other some people use sterile water. There was a time when I think saline, when the hurricane hit Puerto Rico, it was tough to get saline, so they were using sterile water instead. So as long as the viscosity is the same as saline, I probably wouldn't use, Guinness beer. It probably wouldn't be a really good idea. But as long as the viscosity is the same as saline, I think you're safe. But I know some clinics do use Vosh for some of those, deep tissue injuries, or those pressure heel ulcers or sacral ulcers, where they just want some odor control.
Great. So I know you mentioned, there were multiple discussions about using the applicator tip. I know obviously you talked about it in the clinical perspective. I know that Ryan talked about in the ROI, and Wes talked about the promotional offer. Why can't I just use the same applicator tip on every patient? Why do I got to get new applicators tips?
Well, I asked that same question, but no, you can use the applicator tip over, as long as it's in the same day and it's the same patient. You just don't want to be cross-contaminating, and your timer that's on the wand is set up so that once it's up, it's gonna deactivate. So it's built in.
Okay, so when you say that you can use it on the same patient on the same day, if for some reason, and if they came in the morning and I don't know, something happened, you didn't get to finish your treatment. I don't know what it was, but can you use that same tip later on the afternoon if the patient comes back, or is
I would say as long as you don't have another patient in between, because you're gonna have to reset it. If you have no other patients, you're just letting it sit there. You can do it that way. Okay.
I know you talked a little bit about not doing any other billings when you're doing the UltraMIST. Does that mean even if you're doing other medical condition, they came in for a wound on one foot and they have lymphedema on the other foot, and you're putting on a Una boot or doing something? Was that what you were trying to indicate, that we couldn't do any other procedures, or could we use appropriate modifiers to indicate that there are other conditions being treated at the same time we're doing the MIST?
That's correct.
Although I have had situations where there was a totally different issue on one leg, and we did do ultrasound, and the way our billing people use modifiers, they did get it covered. It just, the documentation had to be exactly perfect for it to. And then I think it actually ended up getting, they asked for the notes, etc. But normally it's UltraMIST is the treatment. So a lot of times, if I'm doing that evaluation every 2 weeks or so, after every 4 to 6 MIST, then I'll do my debridement, my evaluation, etc. And then the rest of the time it's just the MIST.
Okay.
But I don't know if I wanted to add to that.
Ryan, I will tell you that, because I can tell you for me personally in clinical practice, when I had patients that actually had venous stasis wounds and I was going to dispense a DME compression device, I actually have dispensed devices on the same day that I was doing a MIST therapy and had no problem getting reimbursed. So is there a difference between DME at the same time as MIST versus a CPT procedural code? Does that make sense with what I'm asking you?
It does. So all I can speak to is anecdotally. I can tell you some MACs and some medical reviewers have no problem. On that, if that particular device requires Uniboot or something requires a prior authorization, I would tell them at that time, I intend to use build this other procedure. Is there something that I need to document or something like that? So just be very cautious when you're doing doing a DME item with a disposable procedure code. So if you get it's something kicked back, why, and you know what to do. They can always talk and get a medical review again. And we have literally done thousands of these, and I can count on my hand where we missed over the claim figured out and overturned and approved. So.
Okay. I've got another question for you. the way the MIST is coded, what if a patient has multiple wounds? Is it the same reimbursement for one wound versus 3 different wounds? How does that work when you're seeing a patient that may have multiple wounds that need MIST therapy?
Good.
I was going to say, Dr. Mrdjenovich, you probably had this happen. So
I have it happen all the time, and we usually just bill for the 97610, and that's it. Because I don't think you can. If you have a calf wound and you have a foot wound and you have an ankle wound, it's the same as when you debride it. You're not going to break them down, so it's kind of like a one and done.
It really is. We've seen it a couple times where they did bill for left, right. One was an inner thigh and one was a DFU, and they did get paid. But to Dr. Mrdjenovich's point, I would not push it too well. You've got to remember, this is a 10 to 15 minute, wanding. So
right.
Not the insurance companies see it as one, but if you do have that happen, there's another one where I would reach out to Medicare or that MAC and say, I have several wounds. They're in different areas. It's caused by different comorbidities and things. Can I do this? And see what they say. But most of the time, I would just bill once.
Okay, and I just from a little bit of my experience, I'll share with you guys that when you treat wounds, the wounds that are treated by the location and the depth of the wound. And I've had situations where I did have patients that were having MIST therapy, and in the treatment course of having MIST therapy, they developed another ulcer that actually needed debridement as opposed to using the MIST. And I have used the debridement codes with the appropriate modifiers and the MIST code at the same time, because in theory, and that's where people don't understand the specificity of the new ICD-10 codes, where if you use the right L97 code that indicates that you're doing MIST therapy for the wounds that are located on L97 512 and 522 versus L97 422, and I think that you put yourself in a very good situation that you are going to get covered for the services that you correctly provide for your patient. So that's just my personal experience that I've had, but that's based on the importance and accuracy of your documentation.
Exactly.
I'm going to ask one last question. I normally try to end on time. I know that Wes mentioned it before, but Wes, what is the rental price for those that want to lease or rent the MIST machine?
$550 per month.
Great. I'm going to tell you all again, as I said when I started before.
Dr. Krause, can I add one thing?
You sure can. You can call me Ira too.
Well, you always tell me to, but no, we do apply the cost of the rental to a reduction in the cost of the machine. And I was just texting back and forth with Mike Geske, is that moving forward, just the financing option is not there just for 2 months. The financing option will be there into 2021. We just need to finalize that plan with Mike. But we will take the cost of the rental off of the machine and apply that to the purchase price of the machine. So that's something that can be worked out with your local representative. That's a common program. It's a standard program that we do. So thanks for asking that question, Dr. Krause.
Oh, no, it's my pleasure. And I want to just, as I said when I started, I think you have to believe in what you do and how you do things. And I had great results utilizing this machine. I really, I appreciate Dr. Mrdjenovich for coming on and sharing his wisdom with us. I appreciate Ryan for coming on. I appreciate Wes for doing things. And I appreciate Mike for being here to answer any questions, which I didn't really get any on the financing part, but having a good partner to be able to make this work in your practice is critical. Again, I want to thank everybody for joining us on Taylor Tuesday. Our next scheduled Talar Tuesday is going to be postponed until November 10th due to the regularly scheduled time being a fairly big night in this country. It's election night, so we've opted not to have any educational programs. So we want everybody to take the night off and vote appropriately. And I will tell you, I'm excited to announce that the presentation for Talar Tuesday, November 10th, is going to be a billing and coding forum. I will be hosting my good friends, Dr. Mike King and Dr. Jeff Lehrman, and we will be talking in generalities about a hodgepodge of different coding events and coding things that are going on, briefly talking about the new E&M 59 modifier issues, the new COVID-19 code, and we really want to open it to Q&A. So I will be having Siobhan probably send out some surveys and questions to people who sign up for the upcoming webinar. But again, I want to thank you very much for joining us on Talar Tuesday. SANUWAVE, thank you for sponsoring this. Thank you for being here. It's really been a pleasure to work with Wes and get a chance to meet Ryan. And if there's any other questions that I didn't get answered here, I'll make sure we get answers to them. But have a great evening and enjoy the rest of your night.
Great. Good night.
Thank you, everyone.
Thank you. Bye-bye.
Thank you. Bye-bye.